So it's an honor to present the final session today in the event that we'll have, the European Harm Reduction Conference. It's fantastic to see so many of you here. And in this final session, we're going to talk about drugs, the real thing, the thing that, the psychoactive matter, the thing that makes things happening in the brain. Today we're going to speak about synthetic opioids. I don't have to explain it in detail because synthetic opioids is that what you've been reading about in the newspaper about the situation in the United States, 80,000 deaths. In Canada, Estonia. In this session, we will speak about the results of a European project called SOPREP, Synthetic Opioids Preparedness. And the main question of this European project is, how is the situation in Europe? I remember a conference a couple of years ago in Montreal, and there I witnessed the tremendous impact of fentanyl, of synthetic opioids on the community, on politicians. I spoke to the health minister. And I came back in the Netherlands and I asked my colleagues, are we going to face something similar? Do we have something similar? And if so, are we prepared for that? And I started talking with other colleagues, and that was the beginning of a European project on preparedness. How is the situation in Europe regarding fentanyl type of substances? And are we prepared? And what can we do in order to prepare for the situation if synthetic opioids will increase? We crafted a special program for you with online interviews, with a real-time interview, and with a couple of introductions and a couple of presentations. And we'll end with a panel discussion in which we will elaborate on what is the current situation in Europe, what are overall trends that we might expect and that we can be prepared of. But let me think, did I forget something? No. Then I would like to ask to start the first presentation, which is a presentation by my colleague Lisa Strada, who couldn't unfortunately be here. Lisa is a scientific researcher and has a specialization on opioids. And she's going to speak about the background of synthetic opioids. Please start the presentation.
Everyone. My name is Lisa Strada. I am a scientific researcher at the Trimbos Institute in the Netherlands, and I would like to introduce you to the topic of synthetic opioids. I will talk about what synthetic opioids are, describe some recent developments in the world, and try to paint a picture as to why we in Europe should really be vigilant about a possible emergence of synthetic opioids. So, let's start with what are synthetic opioids. When we talk about synthetic opioids, we primarily think of fentanyl and fentanyl derivatives, as well as the other more obscure NPS opioids such as U47700. However, we also need to take into consideration diverted prescription opioids and diverted OST medication, because these are actually quite prevalent on the black market in some countries. The EMCDDA monitors NPS in Europe, including new synthetic opioids. Between 2009 and 2020, 67 new synthetic opioids were detected, of which 10 were first reported in 2020. So the number of newly reported synthetic opioids has remained roughly the same each year since 2016. So roughly 10 new synthetic opioids were reported per year. Synthetic opioids like fentanyl are dangerous and of concern because of their high potency. They're associated with a very high risk of overdose. And here you see a visual of the amount of a substance needed for a lethal overdose. Fentanyl is about 50 times more potent than heroin, and carfentanil is 100 times more potent than fentanyl. So how did these synthetic opioids even appear on the drug market? There were two main developments in drug markets in the past decade. There was an increase in new psychoactive substances, as well as the emergence of online drug markets, which have made it so much easier to buy drugs and to have access to different kinds of drugs. And both factors led to an increase in synthetic opioids. It is also becoming a drug of choice for cartels because synthetic opioids are highly profitable and easy to smuggle, given that only very small doses are needed for a user to have an effect. Just as an example, 1 kilogram of fentanyl is worth $5,000, or 1 kilogram of fentanyl that's worth $5,000 in China makes a profit of $1.5 million when sold illegally in the US. Plus, it's cheap and easy to manufacture. With synthetic drugs, you don't have to worry about sun and soil. Now, before I dive into the situation of synthetic opioids, I do want to take a moment and take a step back to understand the wider context that this is happening in. Opioids are not bad in and of themselves. Opioids are a very effective pain management tool. However, the distribution of opioids around the world is very much out of balance. Americans consume 80% of the global opioid supply. Canada and Western Europe use around 15%, and the rest of the world only has access to 5% of the global opioid supply. If we look at it from another perspective, the US gets 30 times more opioids than it needs, whereas India only gets 4% of what it needs. Nigeria only 0.2% of what it needs. So while we always talk about the opioid crisis in the US, there is also another opioid crisis going on in which much of the world is missing out on essential painkillers. But now back to synthetic opioids. We all know about the opioid crisis in North America. That opioid crisis is fueled by fentanyl and other synthetic opioids. In 2020, the opioid crisis worsened yet again. 90,000 people died from a drug overdose, and 60% of these involved a synthetic opioid. Only slightly more died from other opioids, which really shows that it's the synthetic opioids that are driving the fatalities. Here in the picture, it's the pink bar that is synthetic opioids, and the light blue bar that is any opioids. It's also important to know that the opioid crisis was supply-driven rather than demand-driven. This means that fentanyl was pushed onto the market by the cartels, and people started using it because clean traditional heroin without fentanyl simply wasn't available anymore. Here is another graph of drug overdoses. The top line is synthetic opioids, so you can really see how quickly drug overdoses skyrocketed when fentanyl came on the market. There are some recent developments which I think we really need to be aware of because they could also happen in Europe. We know that in North America, heroin and other opioids are laced with fentanyl. But what's really concerning is that in the US, all kinds of drugs are starting to get laced with fentanyl. And the theory is that it's a way for cartels to expand their client base. If I may quote Dr. Noor, the director of the National Institute on Drug Abuse, she said, "Fentanyl is being used to lace a wide variety of drugs, including marijuana. And because of the high addictiveness of something like fentanyl, you will rapidly become dependent on that drug. And then that leads you to crave it, even though you don't know it's the opioid. You'll crave the drug you had that sensation with." In fact, an article from 2021 writes about how fentanyl is appearing in the nightlife scene of New York City. Fentanyl is appearing in cocaine, ketamine, MDMA, counterfeit prescription medication, you name it. And people there are panicking and trying to develop all sorts of harm reduction services at high speed to protect themselves. And finally, this last example also highlights the role of online drug markets and social media. A number of teenagers died after taking Xanax and other pills that they bought on Snapchat. because these turned out to be counterfeit pills containing fentanyl. So synthetic opioids are infiltrating all sorts of different and new populations and settings. Who's to say the same won't happen here? So what about Europe? There has been a steady increase in prescription opioid use across Europe in the past 10 years. And this could be of concern given that this is how the opioid crisis started in the US. What's also really interesting is when we look at the NPS being monitored by the EMCDDA, there has been a decrease in newly reported fentanyl derivatives, but an increase in non-fentanyl synthetic opioids. You can see that in the graph here. The dark blue is fentanyl derivatives. We see that going down, and the light blue is other non-fentanyl synthetic opioids, the color going up. So this contributes to an ever-diversifying landscape of synthetic opioids. Finally, in Europe, we tend to think of opioid users as this aging cohort. However, there are also signs of potentially new populations developing. For example, in Italy, newspapers are talking about the return of heroin, and there seems to be especially an increase among young people. So to summarize, synthetic opioids pose a challenge for a number of reasons. There is a wide range of synthetic opioids and new ones keep emerging. The diversity of users, it's no longer just marginalized people who use drugs, but also drug users from the general population. So people who use prescription opioids or people who unknowingly use drugs that are laced with synthetic opioids. There are different types of markets. Nowadays, including online drug markets, which make it easier for people to access drugs, like the teenagers who died from fentanyl-laced Xanax. Synthetic opioids are usually supply-driven, which makes the situation really unpredictable and uncontrollable when they do appear in the market. And all of this is, of course, of concern because of the high potency and risk of overdose. What is the risk for Europe? There is a clear risk for the existing population of opioid users. There are currently 500,000 high-risk opioid users in Europe. But there is also a risk now for any other people who use drugs, given that drugs like cocaine and ketamine could be laced with fentanyl, just like in the US. And if fentanyl appears on the market, it could happen very fast. Estonia, for example, in Estonia, the synthetic opioid crisis unfolded within just 1 year. And 1 year is not a lot of time to get services ready for, to prevent people from dying. So the big question is, given that this could happen in Europe at any given moment, are European countries prepared for this? And more importantly, how can we prepare ourselves for a rise in synthetic opioids? What good practices are available, and what can we learn from each other and from different countries? These are just some of the questions that we will try to address today. Thank you all for your attention, and enjoy the session on synthetic opioids.
Thank you, Lisa. Now I would like to ask Mr. André Noor to come on stage. Mr. Noor is the head of the Trend and Analysis Department of the EMCDDA, and he's going to speak more in detail on the European situation. Mr. Noor is also one of the co-authors of a very important paper which is written, which is published this year. Oh, it's probably in your presentation. I welcome you. Thank you very much.
Thank you. I'm André Noor. I'm head of the Trends and Analysis sector in the Department of Health at the European Monitoring Centre for Drugs and Drug Addiction. I applaud your stamina, first of all, for making it this late in the day, but more importantly, for your continued fight to provide harm reduction services around Europe and beyond. I have to apologize because some of the slides in the last one will come up again, but not to worry. Repetition will be good. And I've been asked to set the scene for Europe. And there are only really three main points I have. One is that the opioid situation in the EU is not the same as in America, and we can see that by looking at some of the data. The second is that there are concerns around synthetic opioids and the supply of heroin. And I would agree wholeheartedly with the previous speaker that we have to remain vigilant, and there is good reason for concern. And at the same point, because we talk a lot at the EU level, at the moment you'll also see that even if there is perhaps less cause for concern at an aggregate level, individual countries face specific problems that they need to address. And I'm going to try and just run through a number of the indicators that we collect and see what they can tell us. Most of the indicators require careful interpretation. All of the indicators have weaknesses, and I'll try and draw some attention to those at the end. But first of all, what I'd like to do is set the scene a little bit by talking about the opioid epidemic in the Americas. Now, we just saw that slide, but without some of the information at the bottom. There were some important articles by somebody called David Ciccarone in America, and I'm sure you'll get a more authoritative version later. But he identified three waves in the opioid epidemic in America. And all three of these have links to supply. So first of all, in the 1990s, there was the overprescribing of opioids as pain relief. And you have a rise in prescription opioid deaths starting in around 1999. Then the Americas clamped down on prescriptions around the 2010 period. And what you saw is a move towards heroin, and you saw a large increase in heroin deaths. And finally, the wave three, with the arrival of synthetic opioids and primarily fentanyls, you see fentanyls increasing there. So you can actually see these in the various points. And so each of these is related to supply in some manner or form. And what is the extent of the devastation that's occurring? It's very, very large. I mean, here you have some numbers from the USA. So specifically related to opioids, in 2020, the preliminary numbers are 69,710, and in 2009, 51,000, which gives you an age-adjusted rate of 15.5 people per 100,000. In Canada, which has a population of about 30 million, you have about 2020, just over 6,000, 2019, just over 3,500, with rates of 16.7 per 100,000 in the most recent year. And now I want to turn to the EU. And so, overdose deaths in the EU as opposed to America. These are some graphics that we have on trends in overdose deaths in the EU, Turkey, and Norway. For 2019, total number of deaths about 5,800. And remember, these figures don't include the UK anymore, so there was quite a drop. And 76% with a mention of opioids, so about 4,300. Now, if you remember back to the previous slides, far less. And not only far less, but the rates are far less. And then if you look at the age distribution, you can see that where these deaths are occurring is largely in the 35 and plus age groups. Whereas when you look at the American data, frequently it's a bit younger. So that's why we're thinking in the EU, it's largely amongst an aging cohort of users. So that's one of the indicators we have. If we turn to the next one, the estimates of high-risk opioid use. Now, high-risk opioid use is very, very difficult to estimate, and it's done using indirect methods. So we don't go out and count people, but what we do is we construct multipliers, or we use capture-recapture methods, statistical methods in order to estimate them from secondary resources. And here, what we see is that, and this indicator really doesn't fluctuate very much, and so I'll talk a little bit about that at the end. But so we're seeing actually about 1 million in the EU. And the large countries swamp these figures. So Germany, Spain, France, and Italy, very important. Okay, now treatment, another one of our indicators on drug use. And here, what do we see? We see first-time entrants with heroin as primary drug in the EU, Norway, and Turkey, declining over a period of time. If we look at opioids, a larger group, the same pattern, declining over a period of time. And if we look at the proportion of those who go into treatment who say that their main route of administration is injecting, we also see that declining over time. So when we talk about first-time entrants, because if with opioids you're likely to go into treatment on a number of occasions, first-time entrants are people who haven't been recorded into treatment before. So it's the closest you're going to get in terms of incidence into treatment for opioids, which is declining, and also the proportion injecting is declining. So all in all, that looks like cause for celebration or the like, but it's not as simple as that. We have a dynamic opioid market. If we look at seizures, we can see that actually seizures fluctuate a lot because crime and law enforcement agencies their activities will impact on the sort of numbers you get for seizures. But you do see that seizures of heroin are increasing. Some 20 tons in Turkey, but even in the EU states, it's also increasing. We do get data for seizures of the synthetic opioids, at least some of them, so tramadol, buprenorphine, fentanyls, and methadone and others, but those are in the kilograms, not in the tons, and they tend to be located in specific countries. I'll say something about that in a minute. We have an early warning system for new psychoactive substances at the EMCDDA, and this is a very useful source of information, and it's event-based information that is collected around Europe. And this is a graph we've seen before, and what you can see is we're still getting new first-time detections of opioids in the early warning system. Okay, fewer fentanyls, perhaps, but they're still occurring, and they're always of concern. So what we see also is that some of this is located in specific countries. There are fentanyl derivatives in the Baltic states. And we also, just looking at breaking down those numbers a little bit, you've got 67 new synthetic opioids between 2009 and 2020, 10 in 2020, and 430 seizures of new opioids were reported in 2019, 17 kilograms. A lot of it sold online. At the EMCDDA, we also undertake risk assessments at the request of the European Commission on specific drugs to understand what extent they are causing a risk to health and harm of the citizens of the EU. And when they do that, they collect information specifically on the deaths related to those drugs. And what we can see that actually some of the even more potent fentanyls, I'll try and pronounce these, but I'm not very good at this, cyclopropylfentanyl, carfentanil, and acryloyfentanyl, they've been associated with deaths of 78, 61, and 47, respectively. So it's still a big cause of concern. The method of delivering the drugs is also developing. So we've got fake Xanax, we've got nasal sprays from Sweden, and we've got also just the usual ways in plastic that these drugs appear. Okay. Now, one other area that you would see the effect of an epidemic is you would see large numbers of emergency presentations in hospitals. We have a sentinel system of collecting information from hospitals around Europe. It's showing an increase. I mean, clearly, lots of people are still going into hospital for heroin, and it's increasing since 2017, but not to a huge extent. But remember that this is a sentinel system which will just give us some indication of what's going on. These are all aggregates. So what I've tried to do is show you some of the indicators that can be seen as positive and some that can be seen as negative. But the aggregates hide individual country circumstances. And one of the things that you can see from the opioid epidemic in the United States and in Canada is that it's geographically located. So if we have only a few countries experiencing it, it might be a similarity with the America's experience, because the deaths in America tend to be located in the Northeast and in the Midwest. But so here in Europe, we find different countries have very different drug cultures and histories that impact on how drugs are used and what drugs are used within those countries. Finland has an opioid market that has long been characterized by buprenorphine. The Netherlands, one thing we saw in a recent expert meeting at the EMCDDA was a presentation from Trimbos where they were showing that deaths with the mention of opioids was increasing. There is a group in the Scandinavian countries which looks very carefully at drug-related deaths, and Denmark has been reporting deaths from methadone. Seizures, I've said before that the seizures were in kilograms of methadone, buprenorphine, tramadol, oxycodone, and fentanyls are being reported by a range of countries, including Finland, Sweden, Latvia, Belgium, Greece, and you'll hear about Estonia, I'm sure, more later. So, where do we end up with? We end up with a number of things that are positive. Number of drugs related to deaths are stable and relatively low. Deaths are increasing in the older age groups. First-time treatment for opioids is declining. The proportion of those entering treatment with primary drug opioids who report injecting as the route of administration is declining, and high-risk opioid users estimates are stable. On the negative side, we've got seizures of heroin are increasing. Seizures of synthetic opioids are evident, but localized in specific countries. Early warning system is finding more synthetic opioids. Hospital emergencies are going up a little bit, and individual countries have specific opioid issues. What does that lead us to conclude, or at least lead me to conclude, is that the opioid situation in the EU is not the same as in the Americas. The scale of it is very different. There are concerns in the EU around synthetic opioids and heroin supply, and individual countries face specific issues with various types of opioids that are important. I just have two more slides. One is about the reporting limitations. In all of these indicators, there are issues around underreporting and reporting delays and definitions and country comparisons and the like, which is why it's essential to look at a group of indicators together and look for large movements. Interpreting small movements would be pointless. Secondly, one of the issues we haven't addressed here is that because we're focusing entirely on synthetic opioids and opioids, that most drug-related deaths are polydrug use. Polydrug use is the way people use drugs. And so if you looked at these drug-related deaths through a different lens, you could perhaps be looking at something like stimulant deaths and the number of cocaine deaths that included fentanyls. And so it would be very important to really go and look at drug-related deaths when you had more time and we could look at more closely. The third and final thing is that there are shortcomings in our understanding of some specific areas. I am very, very aware that we need to have better differentiation between the different types of opioids in our data, and we're working towards doing that. Additionally, the monitoring of prescription medicines is it's not well developed at the moment. It's not necessarily our main area of concern, but there's clearly need to develop that, and INCB is the International Narcotics Control Board are the ones who actually monitor the use of opioids within the health systems because they have to report on them. Importantly, as a final point, and I think this is important, is that the harm reduction services in the EU are different than the ones in America. And I think that here what you see is that in dealing with an awful situation that may occur, the harm reduction services are going to be extremely important. So we have some of the programs that we have or that you have are supervised drug consumption rooms, take-home naloxone, treatment, outreach, NPS, needle and syringe programs, and others that we list above that are very important. And one final point is that it's clear that supply is one of the main causes of this problem. The harm reduction services can alleviate the consequences of the supply. So we have to be very, very careful because the conditions that occur that would make it easy to move from one drug to another could well occur and could well occur quickly and may well even be occurring in some countries already, and it's just very difficult for us to know. But on balance, I would say that in the EU, at least at the moment, that we are not facing the same sort of epidemic that we're facing in America. Thank you.
Thank you very much for your splendid presentation, and you did it perfectly on time. So, does anyone have a question or a comment whom he would like to address to Mr. Noor? There is one hand. Oh, no. Do you have a loud voice?
You can hear me now, yes.
Yes, yeah.
So I have a question, a comment more like. I found the previous slide very interesting about the main areas of focus. However, I did not notice anything with regard to testing by the users. This is something which gives the user an indication if, for example, the product has been tampered with synthetic opioids. And I was wondering what could be the role of the EMCDDA to encourage governments to allow and push this type of policy. Thank you.
Thank you for the question. Can you hear me? Okay. There. It's working, good. The EMCDDA works very closely with the, what's it called? We call it TEDI, which is the Trans-European Drug Information System, which is a network of drug checking organizations around Europe, including some of the people that are here. And we use that to collect information on the drugs that have been submitted for checking. The issue of drug checking is very complicated and is something that we discussed in our meeting earlier on today, because and it depends on what your perspective on it is, in that in some instances, particularly for things like heroin and fentanyls, the question is whether or not knowing what's in the drug is going to change behavior. And it's not always the case that it does. We've seen evidence from Canada where they do quite a lot of drug checking and somebody finds that they've got lots of fentanyls, but that's actually an attractive thing for the user because many people are actually going for what is the strongest thing. Having said that, the importance of drug checking, I think, is undeniable. It's a very important issue that we are following very closely and using to gather information on. And I would say that you're absolutely right, that it's an area that has to be developed further so that people can be better aware of the drugs that they are taking.
Thank you. I see several hands. May I have to apologize. Perhaps at the end of the session there's more time for questions. Or not. But then we've got an entire evening to continue on this. I would like to thank you again for your contribution. Part of our project is that we try to learn what has happened in the United States and Canada. And our colleague Babak Moazen from the University of Applied Sciences in Frankfurt has prepared an interview with an American specialist. She's Jennifer Carroll. She's a medical anthropologist, and she's assistant professor at the North Carolina State University, and she will speak to us. May I ask to start the recording?
Hello, I am Jennifer Carroll. I am a harm reductionist and medical anthropologist based in the United States. It's my pleasure to be speaking to you today about the opioid overdose epidemic in the United States, where we are now, how we got here, and what we need to be doing about it from this point forwards. If you have ever seen anyone give any history or explanation or any kind of presentation on opioid overdose in the United States, chances are good that you have seen this graph. This is typically how our public health authorities and experts talk about the opioid overdose epidemic in the United States as something that has happened over time in the last 2 decades in 3 distinct waves. The first of those being death from prescription opioid overdose, followed by a wave of heroin-associated overdose fatalities beginning in 2010, and then starting in 2013 to 2014, the takeover of synthetic opioids like fentanyl and fentanyl analogs in our illicit drug market, that now becoming the leading cause of opioid overdose fatality in the United States. So this chart tells us a lot. It paints a pretty stark picture about how rapidly the drug market has changed. But I do also believe that this chart leaves quite a bit out. So specifically in the first wave, when prescription opioids were becoming a larger and larger public health concern, we know that at this time, Colombian heroin in the United States was occupying a larger and larger market share in the illicit drug supply. Prescribing of oxycodone, for example, increased by 600% over an 8-year period. But we do know that even in this early stage of the opioid overdose epidemic, polyopioid use was common, and many people used both heroin and prescription opioids interchangeably or at the same time. So this hasn't always been a purely prescription opioid-driven problem. The second wave, when heroin-associated deaths began outpacing those of prescription opioid-related deaths, I want to draw your attention to this point in the chart. There's an angle, right? There's actually a corner there where you can see that the rate of heroin-involved deaths really started to climb. And that should tell you that something happened in 2010 that changed the risk environment that people who use drugs were living in the United States. In 2010, our Food and Drug Administration approved a reformulation of OxyContin, a long-acting opioid analgesic that had, for a long time, I think represented a large market share of the types of prescription analgesics that were being diverted and misused or used non-medically. What this ultimately did was take a substance that was widely available and was safer than heroin insofar as it was regulated, it met safety standards, the dosages were very clear, and took it off of that market. And we saw a huge shift over to heroin. We know at this time also that heroin is purer, it's cheaper, and because of the glut of Colombian supply, much more prevalent. At this point, we also know that overdose begins to rise, hepatitis C infections begin to rise, and multiple studies have associated that specific change with this regulatory action specifically. Then in 2014, with the rise of synthetic opioids in the illicit drug supply in the United States, we had this wrongly assumed but very widespread and very well-believed idea that was perpetuated, especially by many law enforcement organizations, but not only, that fentanyl was appearing in our drug supply because of user demand. The story was that people who use drugs were seeking this ultimate high. We now know that that's not true. And in fact, unpredictability of the drug supply as fentanyl was coming into it became one of the primary drivers of overdose risk. This is now very well established as a supply side phenomenon, so something that was happening way up the chain, and people who used drugs were very much being caught off guard with an unpredictable supply. So this also meant that home strategies or folk strategies for avoiding fentanyl or staying safe while using fentanyl became much more prevalent. People started trying to communicate with each other, relying on trusted suppliers, because it really, really became unpredictable out there, and it became very scary. Now, our public health entities have responded to this, I think, very well. This is a document that was put out in 2018 by the United States Centers for Disease Control and Prevention. Full disclosure, I'm the first author of this document, but this was a document that was requested by our CDC. It was vetted by the CDC. It was approved and published and branded by our CDC. And this is a tool that was meant to be available for communities in this really easy to read format, very, very simple sorts of instructions, how-tos, summaries of research, and these were all evidence-based strategies. Things like targeted naloxone distribution, syringe service programs, medications for opioid use disorder like buprenorphine and methadone, removing prior authorizations from health insurance coverage of those medications, providing all of those services to people who are in jail or incarcerated. And we had for a while a very data-driven approach, or at least our public health agencies were promoting a very data-driven approach to opioid overdose in the United States. Well, here's where we are today. Across the country, we've had a nearly 30% increase in overdose fatality just in the last year. 30%. We're losing so many people. So what's holding us back? What's not working? Why is our evidence-based approach to opioid overdose failing to stem this cascade of overdose fatality across our communities? I think there's a few reasons. The first one is that we are still not listening to people who use drugs. I think it's important to note that our most effective overdose prevention strategies, syringe exchange, naloxone distribution, drug checking, these are all innovations that have been brought to us by people who use drugs. And even though some of that insight appears in what our public health agencies are doing, there's plenty of things that people who use drugs are telling us now that we're not listening to. For example, there has been really well organized advocacy around methadone in the United States, a drug that is very much kept under lock and key and is only dispensed through a very carceral, very punitive approach that's a huge barrier to care for most people. So while we are debating whether or not to criminalize new fentanyl analogs or allow fentanyl test strips to be purchased with federal funds, we're failing to address very fundamental models of access to care. Second, in the United States, we fail to recognize how our racial politics skews our understanding of drug use as a social problem. Our criminalized war on drugs was begun in the Nixon administration in the 1960s, specifically as a tool of anti-Black racism, because the idea of who uses drugs and why they use drugs is so deeply tied up with white supremacy and anti-Black racism. Our stories about whether or not people who use drugs are good people or bad people, deserving people or undeserving people, is deeply caught up in our ideas about race. What we see here is a graph of office visits for buprenorphine, another medication for opioid use disorder that is much less regulated and much more easy to access than methadone. Even though we know that opioid overdose death among Black communities is very quickly catching up to that seen in white communities, we cannot get these medications into Black populations. There is no access. And part of this comes down to whether or not patients are shuttled into the more independent system of care for buprenorphine from your primary care provider, or whether they are shuttled into more punitive and carceral solutions like methadone or like prison, most of which do not offer methadone or buprenorphine at all. And finally, we as a society are unable to make this leap from keeping people safe to providing safe supply. If you think back to the first slide where there was that sharp increase in heroin-related overdose deaths after the reformulation of OxyContin in 2010, that is attributable to people switching from OxyContin to heroin or from prescription analgesics to heroin, but it's also attributable to the fact that heroin is much more dangerous than a prescription opioid, even if that prescription opioid is being used in a fundamentally unsafe way. We're able to muster political and social support for certain harm reduction activities like syringe access, like naloxone access, and in fact, even support for drug checking is slowly growing in the United States. At the same time, providing someone who uses drugs with a safe supply, making sure that the drugs they're going to use aren't going to kill them in the first place, is something that is still unthinkable. We need to be able to make that leap between just doing some stuff to keep people safe and really making sure that people have safe stuff when they're going to use, because they are going to use. I want to thank you very much for your time and attention, and I want to invite you to contact me with any questions that you may have.
By the way, Ms. Jennifer Carroll has also written a book on drugs, HIV, and Ukraine. The book is called Narcomania. It doesn't have anything to do with the topic that we're speaking about right now, but the book Narcomania, as I know there's a huge population, a huge crowd from Ukraine at this conference. Read this book and contact the woman. So she's really great. Having that said, I would like to continue with the next set of speakers. We have two people here from Estonia, because when you think that the United States and Canada are far away, Estonia, the Baltic country, has faced a fentanyl epidemic already for 20 years. 20 years. And we have three people from Estonia here in the group. And I would like to ask them if you're willing to stand up and come over here. And we have Mart Kalvet. Mart is a drug activist and
hi,
community member of the drug users organization in Estonia, Lunest. And he will be interviewed by a project partner from the project, Mick Oya, who is a researcher and works at the National Institute of Health Protection?
Health Development.
Health Development in Estonia. Please, gentlemen. It's yours.
Okay.
Hello, my name is Mick, and together with Mart, we will try to give you a short overview of the experiences and lessons learned from the synthetic opioid crisis in Estonia. So, as a short introduction, I would like to say that over the last 2 decades, Estonia has witnessed one of the biggest problems with opioid use in Europe, with the highest rate of overdose deaths until 2017. That was mainly due to the use of illicit fentanyls. But since 2018, however, when the main supply chains were heavily disrupted and the availability of fentanyls has been limited, and with the expansion of Naloxone provision and other harm reduction interventions, the number of overdose deaths has decreased significantly. So, as we only have a short time, I will not go over the long history of the problem in Estonia, but we will try to focus on the present issues. And maybe as a start, I would like to ask Mart, what have we learned from this experience?
I think one of the main lessons from the Estonian experience with synthetic opioids is that the iron law of prohibition still holds. The harsher the punishments, the harsher the enforcement, the more dangerous the drugs. It's been pretty much holding water for 100 years, and Estonia clearly shows that this is what happens if you criminalize a type of drug. A new one comes in its stead, and the new ones are usually more dangerous, but easier to smuggle.
So maybe you would like to give a short illustration of what the synthetic opioid market today in Estonia is like.
Oh yeah. This is like we're seeing articles in English language media mostly from the States, how people are nostalgic for the good old heroin because it's not available anymore. Everything is fentanyl. In Estonia, opioid users are nostalgic for the good old fentanyl because what we have on the market is something else. In 2020, I think Estonia criminalized the first nitazene type or benzimidazole type opioid called isotonitazene. Let's call it ISO from now on. And by the time that it was criminalized and banned by law, there were already new nitazene type drugs on the market. Some of them, I think, have been tested, detected, like etazine from discarded gear, from discarded syringes, testing discarded syringes. But there are others, and we don't even know if our laboratories in the country can detect these things if they don't know what exactly to look for. But Estonian opioid users some of them are very well informed, and they know what's happening in the darknet bazaars. They know what's happening in American opioid user Reddit groups. They check the information regularly. If they see that something new has appeared in China, something new is being sold to the United States and Canada, like nitazines, they know that in a couple of weeks or a month or so, these same substances will be on the market here. And how they detect them is basically by description of the effects. For example, we suspect that recently a substance called etonitazepam has appeared on the market in Estonia because we read from the opioid Reddit groups that it's very, very long-lasting, 2 or 3 days even, and we hear the same from the streets, from people who are surprised by how potent and how long-lasting the new stuff is. But we haven't detected it yet. It's all hearsay. It's just it takes a couple of months to get an answer from the state crime lab, the forensics lab, and by the time we get the actual data, by that time usually the situation on the market has already changed.
I think this brings out the importance of integrating the internet monitoring with drug checking services to actually maybe predict what might be coming, what to look for, as this the synthetic opioid market is just so highly dynamic.
Oh yeah, it's very volatile. Like an example, we got a warning from the police that there has been a wave of opioid-related deaths in Latvia, so we should be looking out for a strong batch of opioids and warn people and distribute Naloxone and remind them of the importance of not shooting up alone and so on. By the time we got this information, China had already banned all cryptocurrency transactions, and all of the places that sold these new nitazene type drugs have shut down. It's not available anymore. So currently we have very diluted, very weak ISO or something like that on the market that's dwindling, and nothing else to shoot up buprenorphine pills. That's basically it.
So, as a last question already, is there an alternative to the toxic supply?
Sure, we heard it from the previous presenter. I would safe supply saves lives, but it has to be combined with drug checking that definitely checks not only for the active substance but also for adulterants, because most of the long-term bad effects of using opioids are not actually related to the substance itself, but the adulterants. And safe supply can be organized in several ways. I would direct you towards Mark Hayden's and Brian Emerson's work, which was published this April, about 3 different models of non-medical distribution of opioids, how to make it possible. Basically, it can be a state-regulated safe supply or non-state regulated or a combination of the two. But it's a longer discussion than this one night, I think. I understand this is highly controversial, but at least it's not legalization. Everyone's afraid of legalization. I mean, politicians are. So let's not call it legalization. It's not market regulations. It's a regulation of supply for people with opioid issues. They can be taught to use these substances safely. They can get a license to do that, and these substances can be prescribed or in other ways provided to the users. Thank you.
Thanks.
Thank you very much, Mart and Mick. It clearly shows that that in some cases it takes many years to get things organized. The first Naloxone programs in Estonia started more than 10 years after the introduction of fentanyl. But it also shows that that combined action is highly effective. And what I also learned, two things. What I thought was highly interesting was the illustration that Mart gave about how the crypto market and the illegal market are combined. So they're not separate dynamics. It's fully intertwined. If something happens in the crypto market, the drug market collapses in a way, like in Estonia. And secondly, what I learned is that a real crisis may demand unconventional responses and unconventional interventions as well. And that's why, for instance, in the US and Canada, they are considering unconventional systems like the safe supply, and that's something that can be considered in our region as well. Then I would like to give the floor to the colleague from Finland, Inari Viskari, and she's going to present on the health preparedness. So we've heard about the potential threat from the US, the response, the experiences in Estonia, but now are we prepared? How does the preparedness in Europe look like? Inari, please.
Thank you. Yes, good afternoon, everyone. At first, I introduce myself. I'm Inari Viskari from Finnish Health and Welfare Institute, and the topic of my presentation today is synthetic opioid preparedness in 5 countries, which are our project partners: Belgium, Estonia, Finland, Germany, and the Netherlands. I will focus during the next 10 minutes on key lessons of synthetic opioid preparedness in those 5 countries. And here are the map of 5 countries. So, our report is based on expert interviews, and my presentation is divided into 3 parts. First, I will introduce some of the needs and challenges, and then I present recommendations, and finally some of the good practices from our project partners. And the good practices are based on our findings. I will focus on this presentation shortly on 4 topics, which are the monitoring systems, health systems preparedness, including take-home naloxone programs, the law enforcement preparedness, which means police, customs, and border forces, and finally the early warning systems. My first point concerns challenges and needs in monitoring systems and data collections. The drug markets are changing and there are a growing number of new synthetic opioids, so it's crucial to invest monitoring systems. Next, I present some of the challenges and some of our findings based on country reports. there is a lack of anonymous drug checking possibilities in Finland, Estonia, and Germany. And then the wastewater analysis provides information on the presence of drugs in real time. Still, synthetic opioids such as fentanyl and other synthetic opioids, other NPS are difficult to retrieve by wastewater because the drug content in wastewater is so extremely small. However, with the rapid development of equipment and analyze technology, these studies will be easier to carry out in the future. And the next topic is healthcare systems preparedness. The biggest, here are just a few examples from our country reports. The biggest challenge is the limited insight into the size, background, and motives of persons using synthetic opioids. And one of the needs is that naloxone should be available to any person who is likely to witness an overdose. However, in SOPREP project countries, take-home naloxone is only available in Germany and Estonia, but pure distribution is not allowed in those countries. In Belgium and Finland and the Netherlands, naloxone can only be prescribed by medical professionals and administered by medical staff. And finally, I would like to highlight one issue, that we need more education and training to prevent overdoses. And the next, I present some of the challenges and needs in safe opioid prescription practices. It's extremely important to address and reduce overprescription of synthetic opioid medications to prevent a potential opioid crisis in Europe. There is a need to develop measures to prevent the abuse of opioids while keeping effective pain management available to those patients who need them. And then we move to challenges in early warning systems. The main challenge is that the international early warning systems has not been developed to be rapid. If the use of synthetic opioids increases in Europe, rapid communication and local early warning systems are crucial. Of the 5 project countries, only the Netherlands has improved its rapid alert system. And then some of the recommendations. First one is monitoring systems. Countries should invest more in scientific research on NPS and online drug markets and include synthetic opioids as a distinct category in service. Drugs checking services such as drug information and monitoring systems, DIMS, in Netherlands, can provide valuable information on new substances and other changes in the drug market. The faster new or dangerous substances are identified, the sooner the public can be warned. There is a need for coordinated and comprehensive monitoring with multiple sources and multi-sectoral input of the availability and use of NPS, including synthetic opioids, in different populations. And then recommendations in health systems preparedness. The most important thing is that take-home naloxone should be widely and easily available to everyone who uses opioids, their family members, and all relevant professionals. Now we move to the next point, which is law enforcement preparedness. The increase of NBS on the European drug market and the emergence of online drug markets with drugs being delivered by postal services, for example, have created new challenges for law enforcement. So law enforcement should focus on supply reduction, including disruption of drug trafficking and trade controls, and improving surveillance against drug trafficking. And you can read more about the methods and other details from our reports. And finally, the early warning systems. So the rapid alert systems are an excellent way to inform and warn the public of potentially harmful substances. And one good option for rapid alerts and information sharing could be digital interventions such as apps, meaning applications for alerting people who use drugs about highly potent or potentially harmful substances, adulterant substances sold under different name or fake medication. And there is also need to get information from people who use drugs and low threshold services such as drug consumption rooms. Information should be used in the preparedness system. Then there is some examples of good practices. Previously I mentioned this DIMS from the Netherlands. It's a monitoring instrument that helps to get an overview of drug situation. And then from the Netherlands, opioid task force. And one good example is this red alert, which is an excellent way to inform people who use drugs about potentially harmful substances. And you can find more information from the Belgium early warning system from our report. And finally, I would like to highlight one issue that several countries have developed good practices, however, they are not being shared, so there is a lot of room for improvement in that. And here are our contact details, and you can contact us if you have any questions. And I thank you for listening.
Thank you very much, Inari. All the reports are on the web, so the North American report, the report on Estonia, on health recommendations, can all be found on the project site, including there's a resource center on interesting new articles that have been published on the subject. I would like to highlight one element that Inari mentioned. Much of the health responses that you've seen are familiar to you. Drug checking, early warning systems, they are all there. There are good practices in some countries. There are excellent good practices in another country. But what is lacking is, let's say, the dissemination, the exchange of good practices between one country and another. And hopefully our project can contribute to it. The collaboration with the EMCDDA can certainly contribute to it, because in many ways we've learned Europe is not facing an opioid epidemic, but we have to be careful and we have to be prepared, and we know what works, and you and I know what works. Now it's time to exchange, let's say, the hardware, the details. One of the elements that in our project is that we will be developing toolkits. In a way, I think, who presented it? One of the, I think Mr. Noor presented the overview of the essential interventions, drug consumption, testing. We're going to develop a set of intervention instruments targeting not only opiates but synthetic opiates. Does Naloxone? It works for opioids, but does it work for fentanyl, and how should it be administered? I would like to give the floor to Ms. Christel Kivimet, who will provide a very brief snapshot of one of the key products of our project. It's currently under development, but we wouldn't like to leave the room without letting you know what we will be producing.
Thank you.
Christel.
Good evening. My name is Christel and I come from Estonia. I am an intensive care nurse and I have worked in the harm reduction field for 20 years now. I started from the prisons and finished up in the Ministry of Social Affairs. So, yeah. Why we need another toolkit? I think opioids are old as the hills and we have quite several toolkits already. Preparation always pays off, and the most important message remain relevant, that preparation is the key. As probably John said before, if you are not unprepared, if you are unprepared, you are too late when it hits you. I can say it very loudly because I just finished my night shift in the COVID intensive care unit and we weren't prepared. And same happened with synthetic opioids in Estonia. We had our poppy, and suddenly we had fentanyl. Okay, we somehow dealt with it, and then we had carfentanil. And suddenly it was pandemic in Estonia. We have lost 2,000 young lives in last 20 years. And if you think that it's not an issue in your country at the moment, or it's not a threat in your country, please think again. So, why another toolkit? The aim is to give practical support to service providers to respond quickly and smartly to threats of synthetic opioids. You cannot be prepared for all risks or for all new substances. We just heard there are too many, well, 67, and new ones are coming. It's not just possible, but hopefully with this toolkit we can prioritize some responses which could have great impact on saving lives. The aim is to focus on 7 responses. I'm not going through all these one by one. Just mention online monitoring, early warning instrument, and drug checking. For example, many new substances may not be detected by standard tests, what we use today. And if you think that Coca-Cola recipe is a secret, believe me, synthetic opioids are ahead of Coca-Cola. So, health is an important topic too. And of course, we have to think how we treat these people who use synthetic opioids. We have to make safer rooms for safer use. And COVID-19 showed us many new possibilities how to use e-health. And Naloxone, oh, it's my favorite theme. I have done maybe thousands of trainings, Naloxone trainings. Naloxones have been very effective. Why we have to rewrite or rethink the guidelines, what we already have? Because every overdose is a product of unique set of circumstances. The window of opportunity to effect successful rescue is different with synthetic opioids. Heroin overdose may not be lethal for at least 20-30 minutes, but with fentanyl, overdose can produce respiratory depression in 2 minutes, and hypoxic damages take fewer time, and very often these damages are more serious. For many decades, Naloxone has been the golden standard. We have Naloxone kits with fixed doses. But what we have learned in Estonia, and also have read some research is done in Northern America, that we need higher doses of Naloxone with synthetic opioids because they are stronger and multiple opioids are often involved, and it complicates overdose management. So finally, if we need quicker responses, higher doses, are we ready? What about country policies? In Estonia, anecdotally, still, only doctor can describe Naloxone. Really? World Health Organization just announced that we are missing 8 million nurses and we are missing 2 million of doctors. And we have 2 minutes with fentanyl. So that's why we need this toolkit. We need to be prepared with or without health care services, with or without policy, country politics. These 7 key responses are doable, hopefully, all together. Thank you.
Thank you very much, Crystal. So far, that's the project website, yes. And now I would like to, we've heard about the situation in Europe on synthetic opioids. We heard about the preparedness in Europe, and we've heard how we can get more prepared for a possible rise of synthetic opioids. That's only one trend, synthetic opioids. In the final part of this session, we would like to speak with the panel on are there other trends that we can expect? Are there other health risks that we need to mitigate? So I would like to ask to come to the stage some of the previous speakers, Mr. André Noor, Mart Kalvet will be on stage, Tuukka Tammi from the National Health Institute in Finland, and we've got 2 more distinguished guests, Ms. Marie-Geoffried Roustid from France, and Mr. Viktor Mravchik, former head of the National Monitoring Center in the Czech Republic. Yes. So in this panel, we're going to focus on other possible drug trends. We heard in the presentation of Alexis Goesdeel, anything is used by anyone and under any circumstance. That's the trend. But how does that look like in daily life, and how can we be prepared for that? So my first question to the members of this panel is, what kind of drug trends can we anticipate? Do you see? Let me start going from right to left. Mr. Noor.
That's using a crystal ball to look into the future. For me, one of the things that seems to be likely, at least, is that what we are seeing is that we're seeing increased deaths where stimulants are involved. And we think that, and we know that the availability of cocaine is increasing through seizures. And we also know that the people who are dying from, in the people who are dying, there are a number of drugs that are reported. So if you're asking me, I would agree with my colleague who suggested that when you stop the supply of one drug, another drug pops up to take its place. People are very imaginative, particularly in supply. So what I would say is that stimulant deaths, I suspect, are going to be rising over the next few years.
Marie, what would you see as a possible trend in your country or in Europe?
So the same as André, I will begin with the same remarks. That's very difficult to answer to your question. I have no expertise to predict the future. What I can say from my country is that I'm still very surprised that fentanyl or carfentanil is not present regarding, if we follow the official monitoring trends in France, but it's probably present in the black market. The trend that we have to face now in my country and in other European countries is a cocaine trend that is increasing a lot. And it seems to me that something that is also very important to address is the topic of health inequalities, because regarding the increase of cocaine trend in my country, it's very linked to social precariousness. And we have a lot of people who are living in the street and using cocaine crack also to endure the difficulty of their lives when they are living in the street. So that's a type of self-medication for them, and that's also why it's very important now to when we think about harms linked to drugs, also it's very important to address the question of social inclusion and to be sure that the government really address the access to stable housing and also the topic of stigmatization of people who use drugs.
Okay, thank you. That's also already part of the solution. Tuukka, what trends do you see?
Well, I'd say it's impossible to say what's the next phenomenon more exactly, but I think the main trend is that new psychoactive molecules are so quickly and effectively developed nowadays that certainly something will come, something that is again more dangerous. So having said this, I think it's most important for us to develop our preparedness system in general, whatever the new trend would be. We should not only scale up harm reduction, but also mainstream harm reduction to general health systems, which are better prepared to many threats already now.
Perfect answer. Thank you very much.
Thanks.
Mart, what do you see?
I totally agree with the other speakers. If it's not opioids, it will be something else. People will always use something, they will always overdose on something. I think the more important question would be where can we find and how can we bribe the people who know what will be the next drug trend. I am pretty sure that, let's say 5-10 years ago, there were people in the world, not only in China but also in Europe, who had a pretty good idea what will happen if the fentanyl supply is somehow disrupted or cut off, which is actually what happened in China. China started tightening the screws and forcing prohibiting more of the precursors of fentanyl and making it very difficult for fentanyl producers and providers to continue what they were doing. And they had a plan B. They had the plan B was nitazines. Why didn't they produce them before? Probably because it's a little bit more difficult than fentanyl. Fentanyl was easier. But I'm sure there are people here in this room, maybe even, who know what will come after nitazines if those screws are tightened again. And we need to get those people on our side and ask them and have them tell us what will probably be the next trends. Thank you.
Well, what to add? In Czech Republic, we have for a long time quite stable situation some years ago, there were some synthetic cathinons appeared on the market, but the extent of use or prevalence of use was not that high, and they basically disappeared for a while. So we still have, in this context of problem drug use, we have mostly methamphetamine for many years already. 3/4 of people using drugs, so injecting drugs, are using methamphetamine, which are domestically produced in homemade laboratories. Then 1/4 is opioid users, and there are some changes and shifts. Buprenorphine is the major opioid, which is good because it has this sealing effect and protective effect. So majority of opioid users are basically at least essentially protected against the overdose. Well, Suboxone and Subutex as well, because it has also kind of sealing effect. But of course, there is polyuse and that increases. But I mean, if you compare the number of buprenorphine users and number of buprenorphine deaths, I mean, there are single cases of buprenorphine deaths. So, a quite stable situation with increase of opioid analgesics. They are coming back. They were used in communist times many years ago. Now they are coming back because, and this is something general for the discussion, people are looking for the best effect for the less money, or how to say, for the best money. And if the drug which is prevalent in the market is not available for different reasons, changes in China, changes in legal framework, police or law enforcement operations, and so on, then the people are looking for substitute, of course, and then anything can happen, yeah? Depending on the supply. But in Czech Republic, the situation is quite stable, which doesn't mean it has to be forever looking in other countries in Europe, for example, Hungary or Estonia. Yeah? So we should be vigilant and prepared, of course.
If you would have, final question, if you would have one recommendation for your government, what would it be if you would have one recommendation to services, manage them here around the room? What would be your main recommendation to policymakers? And we go like that.
If I may start from other way around, yeah, sure. We have heard about 7 essential interventions, so simply implement those 7 essential interventions. They are targeting not only new challenges, but the problems we have now. Coverage of substitution treatment, access to substitution treatment, drug checking, drug consumption rooms, they are not available in Czech Republic. Due to many reasons, yeah, I have to be short. Yeah?
Okay, so your recommendation is do what we know that needs to be done.
Of course. What's recommended?
It's the evidence. I'm pointing to the EMCDDA in a way, but okay. Of course. Mart, what would you recommend?
I would say whatever the measures or interventions are, always involve and include peers, the drug user community at absolutely every step. Because without the knowledge of what's actually happening right now on the ground, you can't really do effective prevention.
Excellent one. Nothing about us without us. That was also one of the key recommendations. Tuukka, what would you recommend?
I just want to repeat what I said before, in other words, mainstream harm reduction. And we've heard that the situation in Europe is not that bad. It doesn't look so bad, but we still should use the opportunity and make use of the American strategy and tell our politicians that this is possible. It's possible that this many people die, and we do know what works, but it's under-resourced, it's a marginal activity for marginalized people, but it should be mainstreamed.
So my recommendation will be to strengthen the financial support for harm reduction And that's what has been done in my country to prevent overdose. We have a very high level of opioid substitutive treatment and harm reduction services that are public funded. But the other recommendation, and that's a way to prevent in an efficient way the overdose trend. Because in my country we have 67 million of inhabitants and less than 500 overdose deaths per year. Even if, as André presented just before, we have a high level of problematic opioid use, but very low level of overdose prevention. And the second recommendation that I have is to improve the level of knowledge of politicians on drug use, because there are a lot of false representation about drug users that are linked to the criminalization of drug use. And it seems to me that it's very important to listen to the voices of people who use drugs, to say to politicians that they have to listen to people who use drugs and to bring a lot from their experience to define better drug policies.
Thank you very much. And the final one is to you, André. What would you recommend? You know,
at which point I'd have to defer to my director. But I think what I would do, I mean, I'm not an expert in this, but I think taking up what my colleague was saying before is that better coordination between different services, because it's clear that drug users suffer from multiple areas of deprivation, be it housing, mental health issues, services, lack of economic support. Many of them appear to be in countries where they don't necessarily have the rights of other citizens, and so it would be important also to extend those services to people who are basically suffering. That's what I would say.
thank you very much. It's 7 o'clock. I would like to thank the panelists. I have the opportunity of making a summary of this beautiful session for 15 minutes, but I'm not going to do it. I would say please give a full round of applause to the experts and everyone who contributed.